just feel free to put them in the chat box. I'll go ahead and get started with the intro, just so that we have enough time to get through the talk and any questions. This week, I know I always say this, but this week it really is real honor and a pleasure to have Dr. Erica Spatz giving grand rounds. Dr. Spatz doesn't need any introduction in this audience, but for the one or two people who have not yet had the pleasure of interacting with
thanks. How are you?
I'll go through.
That's right.
We're just going to have everyone mute, please. I'll go through a brief intro for those of you who may not know her. Dr. Spatz to me is sort of the modern version of I would call her the quadruple threat in academic medicine. She really is an outstanding clinician, clinical researcher, a scholar, a terrific teacher and mentor, an all-around force, and something that's quite rare. Dr. Spatz is a doer. She just doesn't talk. She really bridges that gap between talk and action. She received her undergraduate degree in human biology and psychology as a Posse Scholar at Vanderbilt University. She then went into Ben Gurion University in Israel, where she received her medical degree, drawn there by their focus on international health. Her training continued with internship, residency, and chief residency at Montefiore Hospital in the Bronx. Dr. Spatz first came to Yale as a Robert Wood Johnson Scholar and went on to complete her fellowship here in cardiovascular diseases, where she then joined the faculty. As a health services researcher at CORE, which has been sort of a main focus of her research life here at Yale, her work has focused on individualized approaches to preventing and managing cardiovascular diseases. She's also focused on health disparities across the health system and really focusing on ways to engage patients in their care and advance health equity. She's published a lot of work on assessing patterns of care, on health disparities, on implementation of shared decision-making in patients, on disease presentation of acute MI in young women, and more recent work on the use of digital health technologies in hypertension and cardiovascular care. Here at Yale, she's co-founded Project Access New Haven, which is a network of physicians and hospitals and community organizations partnering around improving access to specialty care in New Haven. She served on multiple national councils, including the AHA's Council on Equality of Care and Outcomes, on Quality of Care, and Outcomes Research. Dr. Spatz is a teacher and a strong advocate for women in cardiovascular diseases and beyond. She's mentored countless students, countless residents and trainees, and is really quite passionate about helping women faculty and trainees in cardiology as they navigate the challenges that are particular in our field and to the things that we do. She's now an associate professor of medicine, the specialty lead for population health at Yale Medicine, and newly named director of the Preventive Cardiovascular Health program at Yale. And today she will speak to us on preventive cardiovascular medicine through a 2020 lens. Truly is a pleasure to introduce today someone who is a dear colleague and a very good friend, Dr. Spatz.
Thank you so much, Oyeri, and it's great to be with you all. This is such an honor and privilege to be here. It's always hardest to talk in front of your colleagues, and I really thank you for this opportunity. These are my disclosures. So I thought I'd start with doing a bit of a Zoom exercise. And I thought I might have you all imagine what care looked like circa 2019. For me, that's cardiovascular disease preventive care. But you can put in whatever your area of focus is here. I know it seems like a long time ago. It seems like ages ago. But this is what it looked like for me. It was, busy waiting rooms, hustle and bustle, epic, that's just, kind of makes your eyes blur. really focusing on the traditional risk factors for cardiovascular disease prevention. We all know them, they appear everywhere. Maybe doing a calcium score, calculating risk. That's kind of our usual typical flow. And then more exciting is that we have this expanding arsenal of medications. And I was looking back over the grand rounds over the past year, and many have focused on these different developments. So whether it's statins or PCSK9 inhibitors, icosapent ethyl, or the SGL2 inhibitors. I fondly remember Dr. Silvio Nzuki's talk about a cardiologist, an endocrinologist, and a nephrologist who walk into a bar together. It was a good one. If you haven't seen it, you should find it on our video. But a lot of exciting developments, and I'm sure that there's been lots of exciting developments in your fields as well. But I think when I look back to 2019, there's a lot of things that I won't miss, and I really look forward to seeing evolve in this new age of medicine. And I think Dr. John Rumsfeld, who's the new Chief Innovation Officer at the American College of Cardiology, summed it up well. The problem is not that we haven't had the advances in science, medicine, and technology. It's that we haven't allowed the system to also evolve in the same period. So today I'd like to do 3 things. So one is to convince you that the current approach to preventive cardiovascular medicine is designed to achieve mediocrity, and that the system must evolve. Second is to demonstrate how real-world data from the community, payers, health systems, and individuals can improve our approach to cardiovascular disease prevention. And third is to encourage the development of and testing of decisional support tools and digital therapeutics to drive more personalized care and improved health outcomes. So thank you so much, Oyeri, for the really nice and thoughtful introduction. It's been such a pleasure to get to know you and work with you over the past year. As most of you know, I've been here for a while, and so I don't want to go through my story, but I've mostly focused on populations. And a lot of my work has taken place at CORE, where we're focused on outcomes. And what are outcomes? Really, it's the end result of our care. And we hit on a lot of different areas. We hit on population health. We hit on value-based care, which includes quality and cost. We evaluate health policies and their impacts, and sometimes we're even informing health policy. And we're really keeping a mind on health equity, looking at disparities, looking at gaps in care and areas for improvement. Harlan Krumholtz has been a main mentor for me. He's the director of CORE, but really has shown us what that looks like to take these concepts and to think about the research questions and what's going to drive care forward. And for him and for all of us, it really always starts with one person, that person's experience, that person's outcomes. And so in all of the work that we're doing at CORE, and we're doing work with lots of big data, whether it's Medicare data or FDA data, really it goes back to the stories of each individual and to the outcomes that are achieved. And I think that that concept has always been front and center for me at CORE with Harlan, and is something that I take very dearly in my work, which is to say, even though we want to scale this, even though we want the scope and the impact to be large, we really, in order to do that, we really need to understand it from one person's perspective. So today, as I start my grand rounds, I'm going to focus on a case, and this is the case of Mr. Green. Some of you have heard this case before, but it continues to burn within me as a main driver of some of the work that you'll hear about. So I first met Mr. Green in 2018 when he was admitted to the hospital with congestive heart failure. On that admission, what you would only need to know is that his blood pressure was 160 over 120. His EF was 15%. And after several tests, he was diagnosed with a non-ischemic cardiomyopathy, likely due to uncontrolled hypertension. In looking back to see how this 42-year-old man could have developed cardiomyopathy and did we have any opportunity to prevent it, I was able to find that he had contacted our health system twice before. Once was in May of 2016 when he came into the emergency department for knee pain. And at that point, his blood pressure was 160 over 100, and he was scheduled for follow-up. He did go to the follow-up visit. He attended a PCP visit. And there we learned that he was a single dad. He worked 2 jobs, one as a Yale janitor and one as a janitor in the public schools at night. He was overweight. He lived in a zip code of 06511, and I'll tell you a little bit more about that in a moment. His ASCVD risk score was 10%, and he was started on statins and blood pressure medications and scheduled for 1-month follow-up. And he didn't follow up. And it wasn't until 2 years later that we met him with a severe cardiomyopathy. So why are we failing? Why did we fail Mr. Green? Maybe you don't think that we failed Mr. Green. Maybe you see this case as something that he failed, right? Like he didn't follow up. But I think if we take a bit of a deeper dive, we can see how many times we fail patients like Mr. Green. So one reason that we fail patients like Mr. Green is that the risks are multifactorial. The risks for Mr. Green, we can only imagine, right? So there are going to be social risk factors, environmental risk factors, community factors, and many of those things feel beyond our control. We're here in our office providing medical care, and they're navigating a world that in many times has the odds stacked against them. These are data about New Haven County, and you can see that New Haven County has the highest rates among nearby counties for hospitalizations for hypertension. If we do a little bit of a deeper dive into Mr. Green's zip code, he comes from a community called New Hallville. It's one of the oldest communities in New Haven. It previously was a very thriving community. There used to be a lot of jobs. There was a weapons company here back in the 1800s that brought tens of thousands of people, and there were restaurants and bars and shops. But in the 60s, changes in housing policy and the closure of this weapons company left many people unemployed and without housing, and crime and unsafe streets and a lot of housing foreclosures started in New Hallville. And the town right now, it's in pretty dire straits, although there's glimmers of hope and rejuvenation there. But there, as compared with other nearby counties, the life expectancy is less than 74 years. That's pretty marked when you think about that there's nearly a 10-year gap in life expectancy for this small community that sits in the backyard of Yale. We know that communities have differences in health outcomes. This is a study that we did a while back, looking at trends in acute myocardial infarction and comparing a 10-year period between 1999 on the left and 2011 on the right. The green implies lower rates of hospitalization for AMI, and the red are higher rates. And you can see that, you know, we've made enormous strides in prevention of acute myocardial infarction. But those same improvements were not the same for all communities. We went on to look a little deeper and to divide those counties into low, average, and high income counties. And as you can see that the circles representing the low income counties continuously have higher AMI rates than the high income counties. And there's a lag here, right? So where we are in 2013, as this data pulls out to, is for low income counties is about where we were in 2006 for the high income counties. So one of the questions is whether or not we can overcome these disparities by good medical care, right? Could we, in our 20-minute visit with the arsenal of medications that we have, can we achieve similar outcomes for these patients? We wanted to look at this in a randomized controlled trial. And since within a randomized controlled trial, care is standardized. And we took the All-HAT trial. This is the largest randomized controlled trial of blood pressure medications done quite a while ago in the 1990s and early 2000s. And if you'll remember in this trial, they compared chlorthalidone with amlodipine and lisinopril and looked at cardiovascular outcomes. The mean follow-up was 5 years. And they enrolled patients from 623 sites in the United States. They also enrolled it outside of the United States, but we focused solely on mainland USA. And here what you're seeing is a map where we divided by color the enrollment sites based on the income level of that county where the enrollment site exists. So the red sites are the lowest income county sites, and the blue ones are the highest income county sites. And then we look to better understand their outcomes. I might say that also that this was a study that was done with Andi Shahu, who was a Yale medical student at the time and is currently a resident at Hopkins and applying for cardiology fellowship, which is great to see. So these are the study outcomes. So we looked at the odds of achieving blood pressure control between the low income and the high income counties. Here you can see that there are significant differences in the odds that any of those participants achieved blood pressure control. In year one, 45% versus 57% in the high income counties. And when you get out to year 6, the low income counties, the participants, about 50% achieved blood pressure control as compared with about 70%. And this is after adjusting for age, sex, clinical risk factors, and adherence to study visits. Cardiovascular outcomes also varied, and they varied in 2 different directions. So one is that the low-income counties, the participants within the low-income enrollment sites had a higher rate of all-cause mortality, as well as hospitalizations and death from heart failure, about a 25% relative increase. Interestingly enough, you can see here that at the bottom of the chart that angina, coronary revascularization, and peripheral artery disease were lower. And it's unclear whether this is because of under-identification of these more discretionary conditions, or if they truly had lower rates of heart disease. So as you can see, I want to, in sum, that the risk is multifactorial, and we can have long discussions about why there are and continue to be differences in outcomes between people living in low and high income places. But they're massive and they feel like they're out of our control. A second reason that we're failing is that risk accrues throughout a lifetime. So what do I mean by that? I mean, we're either, all of us when we're seeing a patient are either in the primordial prevention stage where we're trying to prevent the onset of cardiovascular risk factors. We're in the primary prevention stage where we're trying to prevent cardiovascular disease and events. We're in the secondary prevention phase where we're trying to prevent the recurrence of events. And in all of these times, we're usually looking at a snapshot of a person's health at a moment in time and trying to make decisions based on the data that we have right in front of us at that moment. But really, risk accrues throughout a lifespan. And to really understand how to best prevent disease in this person, we really need to go back to the factors here on the left, all of which have robust data showing that these things matter in terms of people's cardiovascular health. Childhood exposures and experiences, the neighborhood that they live in, the noise level, the safety of that neighborhood, the cohesiveness of that neighborhood, the quality of the housing, work stress, financial well-being, discrimination, including microaggression and racism, relationships, the sufficiency of those relationships and the quality physical activity and eating habits, their psychological health, whether they have negative attributes like depression or anger or pessimism versus positive psychological attributes like optimism or happiness or life satisfaction. All of these things contribute to people's cardiovascular risk, and it's really hard to assess when we're looking at somebody and talking with them with data that show us one moment in time. This is a study done by Nori Allen, who I had an opportunity to meet while she was here as a public health student, and now runs the MESA study at Northwestern. And in this study, she looked at 7 of the AHA's Life Simple 7 factors. Those are on the left: BMI, cholesterol, blood pressure, glucose, physical activity, diet, and smoking. And they took 4 of them, just the BMI, cholesterol, blood pressure, and glucose, because they had really solid data on those. And they combined 5 cohorts and looked at the trajectories of those risk factors over people's ages. And they came up with 5 main trajectories. So basically, the score on the left is the cardiovascular health score, and people are assigned 0 if their BMI is very poor, 2 if it's ideal. Same thing for cholesterol, blood pressure, and glucose. So you can get a maximum score of 8 on this scale. So they assess this over in 5 cohorts over several ages, and they define these 5 trajectories. One, which is the high late decline, where their cardiovascular health remains high, but it declines later in life. And that described about 16% of the population. And then if you look at the bottom line, these are cohorts of people who have intermediate health. And then there's this early decline, and that described about 10% of the population. So why am I telling you this? So based on these 5 trajectories, they looked at carotid intimal media thickness, and which is a measure of atherosclerosis, subclinical atherosclerosis. And you can see that there's this progressive increase in thickness in carotid intimal media thickness based on these different trajectories, so that the intermediate early decline group had the thickest intima thickness. And then here you're seeing that they adjusted for the baseline score of people's cardiovascular health, as well as the most recent cardiovascular health score. And they were able to demonstrate that the differences in CIMT remain significant. And this basically says that we do better if we're able to assess the trajectory of people's health in terms of prediction, as opposed to one single measurement, whether it's baseline or the most proximal score. And this gets to how well we can predict, in this case, CIMT, but the same is probably true for cardiovascular events as well. A third reason that we're failing people like Mr. Green is that risk is personal, and it depends on understanding of health, risk perception, desire, and capacity to do something. So what do I mean by this? We can go back to medical school and think about the health belief model, where people's motivation to make changes in their life really depends on their perception of vulnerability, how they perceive the threat of disease to their health, their valuation of benefits, barriers, and capacity to adopt an intervention, and the likelihood of and basically their likelihood of acting on things is often relates to people's sense of whether or not they can control it. So people are much more likely to get their cancer screening as opposed to do their cardiovascular health screening, mostly because people feel like they have no control over whether or not they're going to get cancer. But if they can control whether or not they're going to get heart disease, they could push it off to tomorrow. You know, I'm not going to start exercising, not today, but tomorrow, something that's within our control. And so how does this affect us, right? So we make a lot of assumptions. So we assume that there's mutual agreement about a person's risk. So if I do their risk calculation, but they have a family history of premature coronary artery disease and everyone's died early in their life, you know, are they going to buy into the risk that I've told them that they have for developing heart disease, or vice versa? Another reason is that we assume that people are sufficiently worried about their risk to do something about it. This was said by Daryl Francis, who's a cardiologist in the UK, who tweets a lot, and sometimes some inflammatory tweets, but he says a lot of really important things in those tweets. And he says, we assume that patients will universally consider prevention to be so desirable that it would always offset the inconvenience of having to take daily medication for life. And this is, you know, I think this is one of the most true statements about prevention, which is that, you know, we think that it's a slam dunk to take a statin every day, but that may not be the case for each person. Another assumption is that once the decision is made, people will take their medication. And we know that about half of people prescribed statins for primary prevention are not taking them 1 year later. About 40 to 55% did not take their warfarin. These are in older studies. And even when we look at DOACs, which are so much easier to take, still about 35 to 45% of people do not take their DOACs. And there's multiple studies that show these similar statistics here. It's pretty disheartening. Why don't people take statins? This was evaluated in a qualitative study and also has been shown time and time again. It's not that people are having side effects, right? It's not the myalgias that are the reasons that people are stopping them. It really has to do with not understanding why they're taking them or feeling uncertain that there was benefits to be derived. People also note that their doctor lacked the knowledge to answer their questions and that their doctor wasn't interested in their input. And so when we think about why people don't take their statins, it really places the onus back on us to educate better, to really engage more around the questions that people have, to explain to people and to get them to buy into why there's benefit, and ultimately to get their input. This is a study that was done by Robin Matthews and Tracy Wang as part of the Translate ACS study. This was an observational study looking at outcomes among people with acute myocardial infarction. And they assessed adherence at 6 weeks post-acute coronary syndrome using the Maresky medication adherence score. And what they found is that many people, you can see here in the cohort, had either moderate and even very low adherence. And the reasons that people cited is a lot of times it was forgetfulness, sometimes forgets to take medication, forgot to take medication while traveling. This is probably one of the most common things that we see, and potentially goes back to not really thinking there was a benefit, right? So even if you forgot it, a lot of people don't end up resuming it. And a lot of people noted that they felt like it was a hassle to stick with the heart treatment plan. When you look at these rates here, 35% of the moderate adherence and almost 50% of the low adherence groups just felt like it was a hassle. And when they looked at what are the predictors and outcomes of adherence, some of the predictors were financial hardship and depression assessed by the PHQ-2. Some of the reasons for better adherence was having a follow-up visit and the provider explaining their side effects. And ultimately it mattered. These are the outcomes of, these are the rates of death based on people's adherence to medications. And here you can see that a much higher rate of death in people with low adherence. That's marked by the green line. So finally, why are we failing? The risk is silent and there's no surveillance. So our health system is completely unaware of missed opportunities. We did this study. This was led by Yuan Liu, who's an assistant professor in cardiology. And this study looked at how do we leverage the electronic health record for population health. We focused on people with markedly elevated blood pressure. So between 2013 and 2017, there were over 350,000 patients who had at least one outpatient encounter in our system. And here's what we looked at. We wanted to see how many of those people had a markedly elevated blood pressure, either over 160 over 100 or 180 over 120, pick your poison. And here you can see that we found about 56,000 people with a blood pressure over 160 over 100 and about 10,000 people with blood pressure over 180 over 120. We looked also to see if these were random or if these were consecutive blood pressure measurements. And here you can see the proportional rates of people with consecutive markedly elevated blood pressure measurements in that range. So there's a lot of people with very, very uncontrolled blood pressure. And I think it goes to say that these people are probably at the highest risk for hospitalization, stroke, heart failure, and so on. Then we looked at the timeliness of follow-up. And here you can see, I'm sorry, this is small, but you can see across this top row, the percentage of people who had no follow-up visit after their blood pressure elevation was 22%. And if you looked at people among those who did have follow-up visits, about a third happened within the first month, about half within 2 months, and about 60% within 3 months. And basically, these are the same for the 180 over 120 group. And then when you look at, did we ever achieve blood pressure control? In 60% of these people, we never achieved blood pressure control. So we have significant rates of markedly high blood pressure, of people with markedly high blood pressure throughout our system all the time, but we lack the surveillance to identify these people in real time and to actually engage with them and do something about it. One of the reasons is that people have high blood pressure and have consecutive visits with high blood pressure is clinical inertia. This is a study that I was very honored to be a part of with Yulanka Castro Dominguez and Bob McNamara. And Yulanka led this incredible study, and I hope to see the results published soon. And she allowed me to share some of the highlights with you. But looking at blood pressure control in the Dominican Republic, she reviewed carefully 340 visits of patients with elevated blood pressure. And what she found is that about 65% had something called clinical inertia, where there was no action taken to address the uncontrolled blood pressure. And if you think that this is specific to the Dominican Republic, I can tell you that there are numerous studies that have taken place in the US and in Europe that show that the rates of clinical inertia are around 60%. So not much different. She also looked at the reasons that people had for not making any changes in the blood pressure regimen. And mostly there were no reasons described. Some people had noted that the patient didn't take their prescribed medication on the day of the visit. The patient reported the home blood pressures to be lower, or the patient preferred a lifestyle change. These all happen. These are all very true. And maybe that in those cases, the blood pressure medication regimen shouldn't have been changed. But what I want to bring out by this study is that we need more data. We need to understand when clinical inertia is happening, if there's a good reason for not prescribing a medication. And we need the surveillance systems to detect this. So this study, I think, is amazing, and it's going to bring about a lot of meaningful changes in the Dominican Republic. But I also think it has enormous potential to be translated here within our own clinical records so that we can identify these cases of persistently uncontrolled blood pressure and develop the mechanisms to bring them into care. So this is basically just a little schematic of what I mean by that. We need digital surveillance so that we can detect the Mr. Greens when they come in with elevated blood pressure. We need digital phenotyping so that we can understand the reasons for poor control. Is it clinical inertia or medication non-adherence, or people who are getting lost to follow-up? Are they issues around transportation? Is that why they didn't show up? And then we need decisional support. So not all of this has to go back to the clinician. Some of it could go to a scheduler or to a pharmacist or to a health coach. Some of this could be done direct with the patient. So we need these kinds of surveillance systems, digital phenotyping, digital supports, and really in order to improve blood pressure control for people like Mr. Green, but as well as for the population of people coming through Yale New Haven Hospital. This was a quote by Carlos Escobar, who's at Advent Health. He says, "We needed to move from data to insights, and then ultimately move from insights to insights at scale." And so if we could take a Mr. Green and see what his journey is like through our health system, maybe we can start to put in place the mechanisms to detect all of the Mr. Greens that are out there and really do this at large. So I spent a long time trying to convince you that our current approach to preventive cardiovascular medicine is flawed and that our system needs to evolve. And it's not because of people not trying, it's just that it's hard. But we need to evolve. And so now I'm going to shift gears and talk about ways that we can improve on this. So the second thing I'd like to focus on is how real world data can impact cardiovascular disease prevention. So what do I mean by real world data? Real world data, RWD, is our data that are generated usually for clinical care and not for research. Usually is observational data. It's data that's constantly being collected in our in the ways that we do business. So this may mean data from the community, so population health data, the built environment, data on climate, social policies, culture. Data from payers may include claims data or performance metrics or cost or registry data. Data from the health system, which would include the electronic health record. But don't just think about Epic, think about all the things that have to feed into Epic, like our imaging data, lab data, pharmacy data, and then data from the individual. And this may be patient-reported data or data that we can get now from wearables and sensors, which is a growing field that I want to talk about, mobile apps, as well as social network data. So there's lots of data all over the place. And the question is how do we bring it together? How do we aggregate this data? What are the systems that we need to bring it all together? And then how do we make it meaningful to clinicians and to patients to really drive forward more personalized medicine? I want to start in the big picture and talk about data and see how that can inform our care. So a lot of my work is focused on population well-being, and well-being really is a comprehensive metric of people's physical, emotional, and social health. And over the years, Gallup has studied well-being in the US population as well as abroad, and really has defined these 5 components of well-being that have to do with people's physical health, their career, their social well-being, their financial well-being, and their community well-being. And they do tons of surveys. You've probably seen them. Oftentimes they'll, based on people's responses, they'll divide people into either that their well-being is low and they're suffering, or it's moderate and so they're struggling, or it's high and they're thriving. And so what does that look like? So for purpose, which is liking what you do each day and being motivated to achieve your goals, you can see how the US population feels about that. And under social, having supportive relationships and love in your life, managing your economic life to reduce stress and increase security, liking where you live, feeling safe and having pride in your community, having good health and enough energy to get things done daily. I like these, and I'm reading them out loud to you only because it feels a little different than the typical clinical outcomes that we often assess, but they feel real. And I know that these feel meaningful, and they are, because when you look at well-being and you look at those factors, you can see that they actually correlate with cardiovascular health outcomes. This is a study looking at life expectancy that we did with Anita Aurora, who's in general internal medicine. And here we looked at how scores on well-being were associated with life expectancy. And here you can see that an increase in the years of increased life expectancy associated with a 1 standard deviation increase in well-being, and based on those different metrics. With the, you can see that, yes, we expected physical health to have an impact, but emotional well-being, people's life evaluation, basic access, work environment, all really contributing to life expectancy. This is a study looking at well-being and electoral shifts. I wasn't involved in this, but just to demonstrate that here, what we're looking at is the well-being, the change in well-being from in 2016, and whether your well-being declined. And here, basically, the outcome was whether or not you changed, the county changed in their voting patterns. So if they went from Democrat to Republican in the 2016 election. Sorry, I'm not explaining that very well. And you can see that the people that, the counties that were more likely to shift in their voting patterns had worse quality of life, or declining quality of life in their on their surveys. And this was true for happiness, stress, enjoyment, worries, or not worry, but smiling, sadness, and anger. So your well-being influences your voting rights. I thought I'd just put that in there. Sorry, I'm not explaining that very well, but given where we are in our election. Another reason to pay attention to well-being, and back to the main focus for our talk, is how it relates to cardiovascular disease. This is a study where we took rates of cardiovascular risk factors and disease from the Behavioral Risk Factor Survey from 224 counties, and we looked at their well-being data. And basically, we divided well-being into 5 quartiles. And here you can see that the highest well-being counties expressed in red or orange also have the lowest rates of AMI, angina, stroke, hypertension, and diabetes. So well-being matters, and if we can capture well-being, we might be able to better understand our population's risk. These are local data from DATAHAVEN. Mark Abraham runs this nonprofit group, and they collect well-being surveys if you're interested. And so we have really rich data for Connecticut on our well-being. And you can see how if I take a risk factor like anxiety, I can see how which factors are the most prevalent in our communities and really try to hone in on addressing those factors. They've done a lot of work. This is DATAHAVEN work studying well-being during COVID, changes in well-being during COVID, and the disparities that have been seen between white, Black, and Latino adults in terms of well-being. And I encourage you to visit their website. It's very informative and can really help you at the bedside understand what your patient might be going through. How can we put these factors into play as well? These are social risk factors and risk of 30-day readmissions. Here we did a machine learning approach, taking tons of different social risk factors and looking at their order of magnitude of effect size with respect to 30-day readmissions. And we were able to prioritize them from highest effect to lowest effect. And essentially we looked at 70 or more social risk factors, and these 19 continuously came up as explaining variation in 30-day risk of readmission, explaining about 30% of the variation in risk. Many of these, if you can scroll the list here, are modifiable. This is just one other study of showing how we can put these kinds of data into action. This is work that we did with the Medicare Shared Savings Accountable Care Organizations. This is a map of those accountable care organizations. And basically, we were looking at how social risk factors are, again, associated with readmission rates. And this is readmission rates for heart failure. And ACOs can say, well, I work with a harder population, right? I work in a poorer area, so that's why my readmission rates are higher. True, but if we could peer group ACOs who are taking care of like communities, we already risk adjust for case mix. We do that all the time, but if we could look to combine ACOs who are practicing in communities with similar health behaviors, social and economic risk factors in the physical environment, we can see how among that peer group, how their readmission rates compare. So in this case, for this particular ACO, we gave them a scorecard and we said, look, your ACO, it's practicing in a community where there's, not the health behaviors are very low. There's a lot of smoking, not much physical activity. There's a high admission risk. Social and economic factors put your ACO at a high admission risk. Physical environment puts you at high risk. However, your readmission rate was low, and it was low compared with other ACOs in your peer group. So what are you doing well, right? Like, can we learn from you, and can other ACOs in your group learn from you? So these scorecards went out to ACOs and are meant to drive conversation around who's doing well, who's not doing well. Can we identify best practices in these cohorted ACO groups based on social risk factors? Okay, so how do we turn real world data into real world evidence is a challenge, and something I've been focusing on a lot is hypertension outcomes, as the case alluded to. And one of the studies that we've been doing is in the Caribbean. This is part of Marcela Nunez-Smith's cohort called ECHORN, Eastern Caribbean Health Outcomes Research Network, where we're phenotyping blood pressure patterns in a community-based population. What do I mean by that? We see this study is looking at blood pressure patterns, and it's really based on three hypotheses. One is that masked hypertension and nocturnal hypertension could potentially explain disparities in hypertension outcomes. That is, for the same level of blood pressure, Black Americans have higher rates of MI, stroke, cardiomyopathy, and renal disease. So are we missing something about their blood pressure patterns that may explain these differences in outcomes? The second hypothesis is that masked hypertension, nocturnal hypertension are influenced by stress, activity, and sleep quality, but we may be missing those factors if we don't use other kinds of ways to capture them. And a third is that if we're able to further phenotype blood pressure patterns, that this sort of interaction between blood pressure, activity, sleep, and stress, we might be able to develop more personalized approaches to blood pressure control and improve cardiovascular outcomes. So in this study, we are using 24-hour ambulatory blood pressure monitors. Matt Berg helped us develop an ecological momentary assessment survey where we're understanding how people are feeling, their stress levels at the time that their blood pressure is taken. And then we're using watch-based devices to monitor physical activity and sleep. And this is just a schematic of how it might look when we capture that data. We can see what people's blood pressure patterns look like throughout a 24-hour period and correlate that with what they're doing or how they're feeling. So we took an early look at our data a few months ago and looked at 66 people who enrolled in the study that had no baseline hypertension. And we found that of these 66 people, only 26 were normotensive. Rates of masked hypertension were fairly low, but many people had sustained hypertension or white coat hypertension. But here's the real thing that I want to talk about is that these rates of nocturnal hypertension or nocturnal non-dipping. Here you can see that the rates are really high, but they vary depending on how we define the sleep period. So if we define the sleep period between 12 and 6, or when the person told the RA that they were planning to go to sleep and the RA set the ABPM device to switch mode into sleep mode, or if we use the actigraphy data for sleep, we can see that the rates of nocturnal non-dipping vary significantly. These are some of the outputs of the data, just looking at how we can compare blood pressure and sleep patterns if we were to use the ABPM device, the actigraph device, and then different ways of doing that. And these are kind of getting under the hood to see how to put all this data together. You know, what I want to say from this is that we have a lot of room. We have a lot of work to do. What defines sleep? So if we're using a lot of different sensors and multiple data inputs, we need to do a better job of figuring out how to give back data in a way that's reliable and valid. And this is a lot of the work that goes into using these devices and figuring out how best to do this. Similarly, we've had a lot of problems with people wearing the 24-hour ABPM. A lot of the machines have broken. It's clunky, it's inconvenient. And this is one of the drivers for some of the work that we're doing with Texas A&M to develop a new kind of device to measure blood pressure using pulse wave velocity from the peripheral arteries. And I'm excited about this work. I really hope that the 24-hour ABPM has seen its day, and we can move on to other ways to measure blood pressure. Fortunately, self-measured blood pressure at home is still the standard. So that's just giving your patient a cuff and having them log their blood pressures. And we've tried to advance this a bit in our clinical space. And last year we formed a collaboration with Cardiology and Pharmacy and our hypertension program. And essentially in this program, we are trying to utilize digital health, pharmacists, and virtual visits in order to improve blood pressure control. So how this works is that during a clinical visit, a person is identified as having persistently elevated blood pressure, perhaps not dissimilar to Mr. Green. They're equipped with a Bluetooth blood pressure device that syncs with their phone. The data streams through MyChart and is monitored by pharmacists. And then our pharmacists do weekly or bi-weekly telehealth visits with these patients. This program was launched in the Cardiology Fellows Clinic, and it's been really a wonderful addition. The pharmacists, at least in the beginning of 2020, were sitting in our clinic and we had a warm handoff to the pharmacist, and they would meet the patient at the time of the visit so that they could then plan to engage with them further on. When the COVID shutdown hit, we were sitting with boxes and boxes of Bluetooth cuffs. And we said, we know that these are needed, but how do we get these to people? And so we partnered with OB, with Heather Lipkind from MFM, and looked to see how we could use these cuffs in postpartum women with hypertension and preeclampsia. So now this same hypertension model is now also caring for postpartum women. We give them the cuff on the labor and delivery floors. They're already in our clinical sites. teach them on how to use the cuff, and again, enroll them in this time it's a 6-week program, really the duration of the vulnerability from preeclampsia. It's really been a wonderful experience to work with our OB colleagues and pharmacists, and the care that they've been providing is really incredible and has brought to light so many of the issues that we are talking about today in terms of the social and contextual factors and the barriers to care. And you can only imagine how those are multiplied when a woman is coming home with a brand new baby, or sometimes a baby who's in the NICU, as many of these babies are who are delivered in women who are prematurely delivered because of preeclampsia. We also recently started a partnership with Project Access, where we are screening for social determinants of health and pairing them with a community health worker if they meet any of our criteria. This is through a CDC REACH grant, which stands for Racial and Ethnic Approaches to Community Health. To date, we've seen about 100 patients, and early data show that we can achieve about 50% blood control rates in our population in around 6 weeks. Hopefully we'll be able to improve on that. In this work, we meet weekly, and we go through a process that's really along the lines of design thinking. You know, can we better understand the problems? Can we distill them for any one person or for populations? Then what can we do innovatively? Can we create new ways of engaging with people? Can we create new prototypes? Let's test those prototypes, and then let's iterate on that. And then this kind of cyclical approach between creativity, testing, and iteratively refining it is basically what we're doing in these weekly meetings. And there's so much more work to be done, but I think it's a start, and I'm excited to see where we'll land. Ultimately, the idea is to provide people like Mr. Green a much more personalized risk assessment that brings together data from the clinical data, from his wearables and apps, including blood pressure, sleep, heart rate, activity, patient-reported data on his stress, mental health, well-being, and then really the community data that we need in order to understand Mr. Green in the context of his life, his social determinants, as well as preferences, values, and goals. And so what I've been working on with Oyeri Onuma is to capture these data into one place, creating dashboards that can bring this to light for both the clinician and the patient, and then hopefully using different kinds of digital therapeutics to engage with them around these factors so that we can improve their blood pressure control. This is a study that we did looking at digital health uptake in a low-income population. This was really to kind of see that, you know, how we're headed for a digital divide if we don't attend to the factors that prevent digital uptake in low-income populations. And so we wanted to understand the facilitators and barriers, and that's what we did here. It was a very partnered study between Project Access, Hugo Health, the primary care center at St. Raphael's, and we designed a study where we looked at the use of mobile health apps through a community health worker. And we sent them surveys through this device. We sank their Fitbits and their glucometers for them, and then we surveyed them about their interest and concerns, and ultimately shared those results with the participants. What did we learn? Many have smartphones but don't have or use email. Text is much preferred. Passwords are a problem. Many people don't remember them, and it's just a point that is hard to get past. Dashboards need to be in people's preferred language, so it's not enough to just put the Spanish language content deep within an app. The whole thing needs to be in the person's preferred language. Most people were not previously using health apps, but were really interested in using them, and we found that community health workers can overcome many of these barriers. We also had to change a lot of the digital health platforms, so Hugo Health worked with us to really meet those needs of the patients. Ultimately, our patients in this study expressed interest in using mobile health apps, viewing their health records, owning their health records, syncing devices. They had concerns about research and privacy, but they valued the community health workers and a trustworthy health team, and were more inclined to use these apps and participate in research when a community health worker and trusted team member was involved. I'm going to skip over this for a moment and basically, we've also been working on designing conversations for how to bring this information to people. Often we're focused on the left with information that we can easily obtain from the chart. But really we need to dig into the information that's not in the chart, really. And so we've separated this out into people's biology and their biography, and thinking about how to design conversations so that we can standardize this and systematically ascertain the information that we need in order to assess people's cardiovascular risk in a meaningful way. This work was that we've been doing in this area has been among women, especially because women's biographical health, even though it's their biology, is often not ascertained. So pregnancy outcomes, I referred to the patients with preeclampsia. Those patients are at higher cardiovascular risk. Menopause, family history, often not ascertained, often not in the medical record, but so important in influencing the cardiovascular health profile. So I'm gonna, I know I'm kind of out of time here. I'm gonna skip right ahead here. So if we look at Mr. Green's journey, we need the digital support tools for surveillance so that we can identify the gaps in care, but we also need the digital therapeutics so that we can engage with them at the time of their visits and be able to influence the course of their cardiovascular health. To that end, myself and Oyiri Onuma have been working together for about the last 6 months to develop a preventive cardiovascular health program at Yale. John Sitara and Margaret Furman have been integral members of this and are going to be part of the core team of preventive cardiologists that are going to be informing this new cardiovascular health program. And in this program that we're designing, there's going to be personalized consultation, really leveraging a lot of the things that were referenced today. Yes, there will of course be advanced lipids, and we've been working with Ari Amani to streamline processes for genetic testing, imaging around non-invasive tests of subclinical atherosclerosis, but also remote patient monitoring using wearables and surveys. And again, bringing this together, the biology and biography, and creating shared goals for that patient. And then that's on the left, and on the right, we're designing individualized programs that can help with ongoing engagement. We'll be leveraging our pharmacy collaborative, and as well as some digital health programs. Some of the target populations that we're most interested in are listed here, and you can quickly kind of scan your eyes. So this is my shameless plug for our program, and this is a consultative program, so it's intended for people to come for about a 3-month period of time where we're working on assessing and modifying cardiovascular risk factors. Oyiri Onuma is going to be leading a trial looking at 2 digital health platforms. One is Vivify Health and the other is Livongo. And these 2 platforms both integrate blood pressure, home blood pressure monitoring, scales, glucometers, physical activity assessments, sleep assessments, and then the data syncs into these devices. And there is a digital dashboard that is patient-facing and clinician-facing and can be used to monitor and modify therapies and to provide additional health coaching. And so we'll be comparing these 2 platforms in terms of patients' experience, as well as achieving their cardiovascular health goals. So when we look at, I'm just going to sum up here, when we look at the 2019 guidelines, all of this is here, but we need to figure out the systems to better implement a healthy lifestyle throughout life, a team-based care approach, evaluating the social determinants of health, and having meaningful clinician-patient risk discussions that really facilitate adherence and improvement in cardiovascular health. So the 2019 in-person visit, I hope, is a thing of the past, and that we can improve on this. That we can improve on this very linear approach to risk factor estimation, where we plug in risk factors and define risk, and maybe we go back and modify it a little bit more, but really to a much more holistic approach to precision medicine. I think Rob Califf, brought this together really nicely in this graphic around personalized medicine, precision medicine, bringing together the clinical, the genomics, the digital phenotyping, the integrative physiology, decision support tools, patient preferences, really to get to this precision medicine approach. So thank you for your time, and I'll take any questions.
Erica, thank you so much for that really in-depth dive here. I think that was an excellent talk. I know we're short on time, but we have a few questions here. Matt Berg, you can just unmute and ask your question for Erica.
Thank you very much, Erica. I think you really have taken on this issue of preventive cardiology. I think you did a really wonderful job in laying out for us a number of the issues and how data and new ways of acquiring data and high technology methods for acquiring data could, in some ways, really help in designing personalized approaches to whatever the risk factor is, hypertension, diabetes, what have you. Earlier in your talk, you really highlighted the importance and the critical role that adherence plays. And, as I was listening to your talk, adherence was the elephant in the room. And while we can come up with all these new ways of gathering data, at the end, the final common pathway is the person collecting those data, the person putting on the wearables, the person using the app, the person who ultimately is taking the medication. And so we're talking about adherence behavior and all of the factors that contribute to non-adherence, particularly after an ACS, like depression with a 35% prevalence of significant depression post-ACS that drives non-adherence. And so what I guess my question is, as you think about and how put a program like this, and as you put it together, where is that adherence piece in working with the patient? Where is that expert in having those conversations with the patient that shift adherence? And there's a wealth of data available and how to do that. And where is that person who is with the fellow working as part of an integrated healthcare team, teaching the fellow how to have those critical conversations with the patient that ultimately result in adherence to whatever you propose for them and better health outcomes?
Thanks for that question, Matt. And adherence is huge. It completely undermines all of the time and effort that we put in with our patients if a person doesn't take their medication. It's been so humbling to work with the pharmacists who on that first visit are seeing a person with persistently uncontrolled hypertension, and to see how differently they are taking or not taking their medications from what we thought. I think that firstly, we need the data to know that a person's not taking their medication. Most of this is happening without us even knowing. But I think when you talk about like, what are the interventions that are necessary, there's a few recurring themes in the literature that I think are so important. So one is the education and the buy-in. And so just assuming that people are going to go along with taking a lifelong medication after a 30-second spiel about a person's cardiovascular risk and how important it is. And then for that person to say, okay, yeah, I'm gonna now go to the pharmacy, pick up refills and do this for the rest of my life. And to think it's still important after I forgot to take it away with me on vacation to go back and say, oh, I forgot that medication. It's so important. I got to get back to the pharmacy and take it. You really need buy-in. And in some cases, I think that some of these mobile devices, the wearables with the biofeedback can be very helpful because people can start to see the patterns for themselves where their efforts actually have real-time rewards, because prevention is the long game and oftentimes people aren't able to actually see the benefits. So in our work, we're trying to bring people into the equation by seeing the patterns of their blood pressures and how that relates to them taking their medication or not. stress in their life or not and such. But I think it needs to be studied. It's a huge problem.
Erica, thank you so much. I know we are, out of time here, but we're getting, so many amazing questions, coming in. So maybe just, brief answers. I'll summarize some of the comments. Yeah. These will be open for you to, reach back out to others who have specific questions. So from
I'm coming. I'm seeing randoms.
Just mute if you're not speaking. So from Jeff Bender, just wondering how telehealth can hurt our ability to achieve these outcomes. And Jim Refkin was also wondering, looking at Canadians, their rates are significantly different from what we have, and whether or not all of this is really related to access to healthcare. And then Pedro de Rubio, talks about how social workers really should be a more integral part of the team, since they can, address these issues more effectively and efficiently than we can sometimes. So I'll just have you sort of do a last sort of quick summary, and, we'll close out. Also kind of, allow you the chance to look through the comments and maybe respond to people individually as well.
Sure, thanks for these comments.
Erica,
yes.
Sorry to interrupt. This is Jeff. I couldn't help but preempt your answer by just congratulating you. This is wonderful stuff. And I've heard a lot of preventive cardiology talks over the years. This is unique. I don't want you to leave and no one's traveling these days to take your show on the road, but this is really a fantastic talk. And my question was really not, does it hurt, but does it hurt or does it help? In the fellows clinic, our adherence, our no-show rate over the years has been 50%, I would say. Now, at least for the telephone or the telehealth telephone visits, it's nearly 100%. But we need to be in the room with people and look them in the eyes and talk to them. So that's the conflict here. And I just wonder what you thought about that.
Yeah, I think the greater availability of telehealth is amazing. It gives us so many more options. But I think it's important that we remember that as an option. I mean, I hope we're not in a situation where that is the only option again. I think bringing these conversations into the forefront with our patients can really help us to figure out what that journey looks like together. So what are the struggles and barriers with coming in? What's going to work for this person? And the answers to that are going to be different for every individual. And it would be a great mistake to put everybody into one category and, to stereotype people and say, oh, I'm sure that transportation is an issue. I'm sure you're going to love telehealth, when that's not the case, or when a visit really needs to happen in order to have that more meaningful in-person discussion, or, so I think we need to be flexible. I think we need to be fluid. I think we need to co-design goals with our patients so that they have a part of the process and that they could have, help to define what that looks like. And I think we'll get better buy-in. I think social workers are so important. We work a lot with community health workers and patient navigators who, know the system and know how to get things done, and really form those relationships with patients. They speak their language, they're from the same communities, and they've been really terrific at helping to navigate this broader world of social risk factors that we are ill-equipped for. We shouldn't be spending our time for. I'm not an expert in these things. It's not the best way to pay me for my time, but really working with our colleagues in an integrated way to address the many factors that are affecting our patients' cardiovascular health.
Thank you.
Thanks, Jeff. Yeah.
Erica, thank you so much. I know we can go on for another hour, and I, thank all of us stalwarts who stayed, through this. Thank you again very much for just an excellent talk, and we'll see you guys again next week.
Thank you.